Thank you. Good afternoon, everyone, and welcome to our Perspectives in Conversation, the year that was 2021. Thanks for everyone for coming. My name is Jenny Phillip, and I'm the Chair of Palliative Medicine, University of Melbourne, St Vincent's Hospital, and have appointments at Peter Mac and Royal Melbourne as well. And I'm really delighted to welcome you here on behalf of Palliative Nexus to our last event, our last Perspectives event of the year. Just as I begin, I wish to acknowledge the traditional custodians of the land on which we're all based at different parts of this great wide land today. I'm on the land of the Wurundjeri people, and I wish to acknowledge the elders past and present. So we thought last year was a big year, but 2021 has just gone that little extra mile. Initially, in January, we saw the invasion of the centre of power in the United States by a violent mob, motivated by a mix of anger and delusion and encouraged by sections of the media and eventually effectively endorsed by many on the one side of the house in that country. We saw countries around the world, including, for example, India, brought to its knees by COVID-19 with images of immense suffering and need as families sought to provide help for their loved ones, and as health professionals responding with everything that they could, and yet still knowing that for many it wasn't enough. And we heard of more than 80 million people on the move, forced to flee their homes, mostly due to violence and conflict, risking everything and often taking long and dangerous journeys in the hope of finding safety and stability. And also there was stories of joy and possibility. In the heart of Berlin, a new place of worship opened, the House of One, a multi-faith centre with the purpose of fostering community and dialogue. It includes a church and a mosque and a synagogue in 3 separate sections, but linked by a central communal dome. And it's going to be open to other faiths as well. There's also, as well as secular society. We heard on a light note that Notre Dame Cathedral, which was ravaged by fire a couple of years ago, had 3 colonies of bees living in the ceiling, and the bees apparently not only survived the fire, but against the odds continued to thrive. And during COVID, they've really thrived, and apparently the colonies are behaving completely normally. And up there amongst all of the joys of the year is the finding of little Cleo Smith after, I think, maybe 21 days missing from her family. And of course, no news coming from the White House every day with daily tweets is very, very welcome. But perhaps some of the 2 of the biggest threats that have continued to unfold this year and affecting all of us have been COVID-19 and climate change. Obviously, they're different in their genesis and they're occupying different parts of our consciousness on a day-to-day level, but have extremely significant global and personal perspectives for us all. We're riding the wave of hope as the energy of the COP26 is starting, and we see the hospital rates with COVID go down and as vaccinations go up, and then in the next moment we feel anxious as we hear of a small and vocal group that continue to deny the science of vaccination, and as we see the compromises of world leaders watering down our ambitions for meaningful response to global warming. We watch different leaders respond, international, national, health service, even in our own teams, grappling with issues of day-to-day and keeping the community safe. And we've watched the ways that these existential and real physical challenges and social threats have highlighted issues of inequality in our world and seen people come together to try to have a collective good. And in Victoria in particular, we're rejoicing in being able to share a cup of coffee with colleagues. So we're coming to the end of the year with a mixed picture and no doubt mixed feelings. And it's within this sort of complexity of human feelings that I welcome our wonderful panel to reflect with us today, this afternoon, on the year that has been. So I might ask the panel to put their cameras on, and we might get rid of that holding slide whilst I introduce everyone. So welcome, panel. And first of all, I'll introduce you to Carmel Smith. So Carmel's had a long and illustrious career, mostly based in regional Victoria. She has a few highlights. She established oncology services at Echuca Hospital, subsequently also at Shepparton Private Hospital. She was the executive manager of Goulburn Valley Hospice Care, a position she held for 14 years, and really celebrates the high rates of care and subsequent death at home, which has been really a highlight for that region. She has qualifications across cancer nursing, palliative care, business leadership and management, and she's been acknowledged with many awards, including from the Australian Nursing Foundation, Nurses Board of Victoria. She's former Citizens of the Year of Greater Shepparton and Life Membership of Palliative Care Victoria. I do need to say Carmel has been in retirement, but she was keen for me to say that, well, she has come out of retirement to do some nursing shifts over COVID, but she was keen for me to just sort of say that she doesn't feel like she's necessarily at the coalface of all things palliative care. But I'm sure you'll agree that she's very well qualified to speak about this year. So welcome, Carmel.
Thanks.
Dish Harath is trained as a medical oncologist and then also subsequently trained in nuclear medicine and PET scan training. His main interest in medical oncology is in lung cancer, and he's the head of cancer services at Western Health, a position he's occupied since January 2018. He's also has a deep interest and a leadership role in digital health. He's a Chief Medical Information Officer for EPIC, which is Electronic Medical Record at Peter May. And this year he's also started the role as Clinical Director of Western and Central Melbourne Integrated Cancer Services. And I'd also like to add that he's a strong advocate and active advocate for the needs of people with cancer in Melbourne's western suburbs. Welcome, Dish.
Thanks. Hi, everyone.
Carrie Lethborg has over 30 years' experience as an oncology social worker, working at Alfred Health and St Vincent's Hospital. She's a founding member of Oncology Social Work Australia and previous chair of Victorian Cooperative Oncology Psycho-Oncology Committee. She has a Master of Social Work and a PhD from Melbourne Uni, focusing on psycho-oncology. And her postdoctoral work was partly developed during her time at Memorial Sloan Kettering in New York. She's published widely and has grant success, and she's also led a team of researchers for St Vincent's Health examining social inequality and injustice, and is now working on a trauma-informed care framework for the hospital. Carrie is a senior lecturer at University of Tasmania and provides staff support for Ovarian Cancer Australia and the Cancer Council of Victoria. Hi, Carrie. Thank you for coming.
Hi, Jill. Thanks.
And Mira, Professor Mira Agar is Director of Impact, the Impact Centre, and also Professor of Palliative Medicine at the University of Technology in Sydney. She's been involved in supportive care and cancer symptom trials since 2004, and during her PhD really conducted world-leading research on a clinical trial of antipsychotics for the management of delirium in advanced cancer. She's inaugural chair of the Cancer Symptom Trials, a cooperative trials group around supportive care and symptom management in cancer, and formerly directed the trials for the Ingham Institute and also for South West Sydney Local Health District. She's a senior palliative care physician, extensive research and trial experience, and held many leadership positions in palliative care. And in 2020, Mira was appointed chair of Palliative Care Australia Board. Welcome, Mira.
Thanks for having me.
So I'd like to begin the discussion today by asking each of you perhaps to comment in turn on what you think might have been some of the key challenges that you or your service have faced in 2021, and also something that's been a bit of a triumph that you've noticed. So perhaps, Carrie, can I start with you?
So I've had a strange time because I have been living in Tasmania, but doing a lot of debriefing work with a number of cancer helplines, and a lot of my colleagues at St Vincent's in Melbourne. I've been tracking how that experience has been. So that's just been strange because we haven't had a big impact in Tasmania. We're bracing ourselves, I've got to say. But it was really interesting to, fairly intimately be following nurses on the helplines and the helplines just became inundated and have remained so. I think when a lot of other psychosocial services just stopped and people couldn't go into hospitals, everyone rang the helplines. And so it's been interesting to watch this trajectory of a whole lot of energy when COVID first hit. So trajectory for staff is what I'm talking about here. And then as the cumulative stress happened and they were living and supporting people through the same trauma, just how hard that's been. And I kind of think when I was reflecting on the year that there have certainly been some areas where we've asked too much of people. Certainly on the helplines, there were a lot of women who were at home with their kids and working full time and trying to do helpline support, and certainly, you know, nurses in the hospitals and allied health in the hospitals that they've been exhausted since the end of last year, certainly. And I wonder about that. I think one of the challenges I've really noted is that a whole lot of things that we have good evidence for in terms of what's required to keep people psychologically healthy, we had to stop. And that's been really hard as someone who's been involved with research in that area and have learnt over time. So things like what we know people who are bereaved need, what we know people who have been diagnosed with a life-threatening illness need, in terms of, you know, their family with them coming in, getting information, being able to call anyone at the hospital that they might need, having that informal checks with nurses when they go in, and being able to have people around them. And equally being in lockdown and having this cumulative stress, but not being able to exercise or be around people. It's really struck me that there have been all these things that we all know are essential for people to cope, and we've worked really hard to make that part of care that we had to abandon in lots of ways, and that's been really hard for me to view. I think one of the triumphs happened for me really early, I think March last year, when there were a group of oncologists who got together and said we need to very quickly review a whole lot of cancer treatment protocols. And so it was very early days, but it was clear that borders were going to close, that people weren't going to be able to travel, for example, from Tassie to Melbourne for treatment and all over Australia. And there were 15 of us who met every night, I think, for 2 weeks straight, and pulled together this protocol that got published in the JCO in record time as a discussion piece, certainly. But that was one of the many times when, I kind of went, wow, what an amazing community we have in the world of palliative care and cancer services across the world, and how everyone just pulled together really quickly. And I remember there were so many ads coming out saying, you'll be fine as long as you're not elderly or have cancer or are unwell. And there was, a quick reaction to get, I think Cancer Australia got, a couple of ads out there very quickly saying, no, we haven't forgotten you. That was a pretty proud moment.
Thanks, Carrie. Dish, would you like to comment on that challenge and or the triumph?
Yeah, so look, following on from what Carrie said, I think the big thing, so I obviously work in hospitals, so my focus is there, but I think really the visitor restrictions were the thing that really hit us very hard. And it's interesting, I think if you'd sort of asked us in March 2020, we would have thought it would have been dealing with all the COVID positive patients. But I think, all the sort of measures that were put in place to manage that, and the actual relatively low rates of COVID in the community meant that the real problem we were dealing with was not the one we were anticipating, which was lots and lots of COVID positive inpatients. It was the impact of the restrictions. And the visiting restrictions, as Carrie said, it had a really devastating impact on multiple levels. It meant that people were not coming into hospital when they were sick, so that put pressure on the community services, the community palliative care services. It meant that they were at more risk of adverse events in hospital, such as falls. Communication was extremely difficult because we often had different family members just not being aware that their loved one was deteriorating, or that what had changed on a day-to-day basis, having to make phone calls to multiple family members. So I think that was just an absolutely devastating impact. And as I said, the downstream effect of that then with community palliative care services was pretty big. The other ones, and there's a few others, but I think certainly having to furlough staff because of COVID and people, being pretty strict about having to take leave obviously had an impact. I think all of these things. So just the other thing, I guess the other downstream effect of the visitor restrictions I should have mentioned was we certainly saw a rise in patient complaints and family complaints, and particularly, if someone had died and they had a bad experience, the family had a bad experience of death because of the visitor restrictions, we had a number of complaints arising from that, and some, still ongoing distress from that. I think if the triumph, the one that stands out for me is certainly that we've been able to maintain really great patient flow and discharge planning despite all the challenges. And I think, calling out Western Health where I work, the thing that's been critically important is the close integration between palliative care and cancer services, so medical oncology, haematology and palliative care, and our strong links to community palliative care with Mercy Palliative Care, even though Mercy have been absolutely hammered. I think that has meant that as we put some of these harsh restrictions in place, and we've been pretty tough about it, we've basically said to people, particularly recently, look, if someone's suitable to go to a palliative care inpatient bed and there's a bed available, rather than the normal process where we'd sort of have family meetings and give them time and get used to it, we just move them. And then we talk to the family afterwards, because we really, we've needed those beds for COVID patients. But, having the integrated services and having everybody working together has really allowed that to happen. And so that's been fantastic.
Thanks, Dish. I'm struck by all the sort of the unforeseen or the emerging consequences of the no visitors, and the issue around surveillance and people just observing deterioration, but also the whole, I guess, lack of relationship then between the family and staff, which hasn't built up over sort of weeks of visiting someone in hospital, and therefore potentially the complaints even more. That's interesting. Thank you. Carmel, I wonder if you're able to comment on the year and challenges and triumphs. Carmel's been having some trouble with her internet, so I might go. Oh, no.
I'm on, I think. Am I on?
Yes, you are.
Thanks, Jenny. Sorry, everyone. I'm living in Gippsland now, and I'm having trouble with the internet. Yes, well, my experience, I suppose, I went back to being clinical after many years in management. The service that I manage, Golden Valley Hospice, is a standalone service in Shepparton, and we are a small team. And of course, when COVID hit, I was the backup plan, so that if the girls had to be off because they'd been in contact with someone with COVID or anything like that, it was me. And I guess that was one of the things that I identified fairly quickly was how hard it is to get qualified staff that know a service and are able to manage a 24-hour on-call position with that, to have the experience to do that. So the things that I noticed as I nursed families through that time, through the 2020 and early 21, I guess was the anxiety levels of patients and of families. I found it really interesting that there was, the level of anxiety amongst our patients and their families was so much higher than I'd had to deal with before. And I reflecting on it, I felt it was because a lot of the other services that were part of the hospital withdrew from the care. So if we had district nursing in for hygiene or whatever management they were in for, they withdrew from home visits a lot, especially during the lockdowns. So a lot of the supports that the families and the carers had at home suddenly disappeared, and they were left with just us. And I found that I believe that was why a lot of the patients were very anxious. We noticed that our after hours calls increased. that patients who had been well managed and who were well supported were ringing with smaller problems that were well sorted out, you know, by just a chat with us. But it was the fact that they were wanting to contact us and wanting to have that discussion earlier. So, and on a practical point of view, it was things like getting PPE gear, like because we weren't part of the hospital, we just couldn't even get gear. If we had a family member that had come home that was positive and the patient still wanted to die at home, it was trying to, we spent a lot of time at Bunnings, I can tell you, and I think so did Golden Valley Health, but it was just trying to do everything to protect ourselves while still maintaining the patient's wish to die in their place of choice and to die at home, and to support the family to do that. So doctors' visits were difficult, even for verification of deaths, you know, all those things that a community palliative care service does and just routinely does. That was just all of a sudden difficult, and we had to rethink how we did all of that. But I think probably the positive for us was that we were still able to maintain our high home death rate. People were still able to die in their place of choice with dignity. And I think I was listening to the doctor speaking about the hospital admissions. I think we worked very hard to avoid hospital admissions under any circumstance, especially when the lockdown was really tight. Because we knew once we got patients in there, it was difficult to get them back out into the community to die, but they were going to be isolated from their families. So we worked really closely with oncology and the palliative physicians to set things up really well at home so that we avoided any unneeded admissions into hospital. If they had to go in, of course they did. So more time with the carers was another thing. So I guess we spent a lot of time outside houses, talking through windows and doors, which is always really challenging, but at least we were still able to be there. And for the Golden Valley, and I'm sure other regional areas, when the Ring of Steel was happening in 2020, I know that became very difficult for us and for our families and for carers, because when loved ones were dying, people snuck out. And of course, you know, you'd get there the next morning to reload a driver or something, and you could tell by the atmosphere in the house that someone had been that shouldn't have been there. And then that started a whole new discussion with the family and just getting prepared for all of that. So yeah, there were a lot of challenges, but still enjoyed working and being back in the community. And from a staff point of view, I guess we just missed that camaraderie of morning handover all together and things like that. Everything was done online. We had Zoom meetings, but they weren't the same. And those conversations you had in the corridor when you'd had a bad day, I missed that. And I felt that the office staff too were very isolated, because the girls weren't coming in and out as they did all day, getting equipment and all those sort of things. So, but look, what it showed us is that we can still continue to look after patients from our homes with IT. You know, it really proved that our IT system of patient management, PalCare, was fantastic, because we could see what was going on very quickly if patients rang, and that made working from home very easy. So I guess that was a positive. And it was lovely going back to being a nurse for a year and a bit.
Thanks, Carol. Mira.
I think from my perspective, my clinical work has been mainly in ambulatory care, and I think most of the patients that I've seen throughout the year has been in the virtual means, and often without video. And so I think that acuity of trying to listen without those visual cues is a very different clinical experience. And I think the generosity of the patients in those interactions, and I think their concern for the well-being of the health professionals, it's a little bit like doing home visits. I think that you're very much in their territory, and it does, I think, change the dynamic. And I think there's something to be learned in terms of our patients taking leadership within our consultations that I think I've reflected more during these last couple of years as something we really need to think more about. I think the other group I really think we need to reach out to is our healthcare interpreters. I know in Southwest Sydney, the tremendous role that our healthcare interpreters have done all through phone interpreters, the conversations that they must have been part of, the communities that they must have seen impacted, and then coming and joining those conversations in a professional way and doing their utmost to ensure people had the information they need with all that anxiety and stress that so tangible on the phone. I think they've done a stellar job, and I think as health professionals we need to really reach out and make sure that they are also supported in their recovery through this whole process as well. And then with my policy and advocacy hat on, I think I really understood that actually policymakers want to hear our stories and hear what is important to enact change, and actually good policy comes out of building relationships with those key people, and that's also very difficult to do in a virtual world. And so I think it's shone a new light in terms of the positive relationships we can have with government and policymakers and our health administrators, and those corridor conversations are as critical, and the absence of those I think is going to be a challenge. And we of course have planned an immense response to the pandemic, but the needs of the Australian healthcare population going forward for the next decade is just as important, and we need to catch up that ground in terms of ensuring we have those policies in place to meet that future need, and don't lose ground. And cancer diagnoses and the conversations around late presentations is another example where we're going to have to really keep the energy up to meet some of those new emerging challenges ahead, I think.
Thanks, Mira. I'm struck, there's a sort of a few threads that are coming through from many of your pieces, and they're very rich. Thank you. I'm struck by, you spoke of interpreters, and Carmel spoke of the office staff, and we are aware of the clinical conversations that are not happening in the corridors, but actually all the additional support and conversations, and people working from home for close to 2 years. And with ongoing likelihood of doing that for a bit longer, there's a lot of support that's not available in the routine day to day. Thank you, Carrie. I wonder if you could think about, and you may have already covered this, but something new that you might have learned in 2021, something that made you stop and think, oh gosh.
I think I knew that isolation wasn't a great thing for people. I think we've all probably liked some of the extra time we've had at home, and the, that we've had an excuse to not have to go and do all the busy stuff. But I think there's some really subtle things that I hadn't quite thought about that we lose when people have been in lockdown. And part of it is a reflection of ourselves that we get when we have just serendipitous, contact with people, when we go to wherever we maybe get our coffee every day, and the person greets you and maybe reflects back about something, what you're wearing or how things are. And I think one of the things that happened was that a lot of us started to second guess ourselves and our sense of significance in the world, and because we weren't getting that feedback that we get from those, the thing I absolutely missed the most was being able to meet a friend for a coffee, out of everything, just to be able to be in the presence of someone. And also, I think the other thing about the isolation that a lot of the country had was that we weren't keeping check on people that didn't live in safe places at home. And so, a lot of us were at home and made the best of all of that and missed people. But we know that there were I think our domestic violence numbers went up by a third within the first couple of months and just continued to go. And, you know, we had these families under more pressure than they'd ever been. So that the importance of community and the importance of connection, and, you know, it is a theme I think we're all talking about, but I think the very subtle things about when we get a reflection back of ourselves from someone, we just didn't have that. And I think that struck me particularly during that time. Those serendipitous moments are really important. Yeah.
Interesting how much they matter, isn't it? And,
Absolutely.
Dish, equity is a key component of the Victorian Cancer Action Plan, and also a number of other policy areas. I wonder, how have you seen equity play out in 2021, and any responses or initiatives that you've sort of noticed or would like to talk to as well?
Yeah, it is. So again, you know, Western Health, where I work, we have a very large CLD proportion of our patients. So, you know, culturally and linguistically diverse patients. And I think, you know, telehealth and some of the comments about interpreters and the impact on them is really spot on. But I think it's interesting. It's a kind of double-edged sword, actually, because I think that on the one hand, so not having to come in for clinic visits and come into outpatients and either having your consult on the phone or on video. So in fact, for some people, particularly if they've got financial struggles, there's been quite a lot of positives for that. If it was just a sort of a routine checkup, and they didn't, you know, say they just had their 12-month breast cancer checkup or something like that, because they haven't had to pay for parking, they haven't had to sit in a waiting room for 3 hours. And often they can actually, as you know, all of you know, they can often actually have other family members or people with them at home at the time when they're contacted. So I think those have certainly been positives. I think with the interpreters, I've certainly had a mix of experiences. I think the interpreters have certainly done a terrific job, you know, in terms of managing this. But I think, you know, I'll often dread when I'm in clinic and I've got a patient who there's an interpreter, because I have to then call the interpreting service, listen to their sort of 2-minute spiel about, you know, or how their service works, which happens every time, then wait for the interpreter to come on and then hope that the connection goes through and that it doesn't drop out and that the patient hasn't, you know, dropped out. And so, you know, and at the end of it, hopefully then you do have that conversation, but it can be challenging. And, you know, I think certainly some families, rightly or wrongly, have just kind of gone, well, that's too difficult. I'm just going to get my son here at home or, you know, my daughter to interpret. So that's that's one side of it. I think that the other side of that equity, though, is, you know, if we think that video telehealth, for example, is superior to telephone telehealth, and I certainly do, you know, if you haven't got access to a laptop or you haven't got the knowledge of the technology, or able to use video on your smartphone or laptop, then you get an inferior experience. So, you know, again, I think that's the other side of the equity thing, that we've got to really be conscious of the negative impacts of some of these people and the struggles they have to participate, you know, when we're running these services.
Yeah, thanks, Dish. I mean, I think, as you say, telehealth can open up lots of opportunities. It's been interesting in palliative care that there's been the opportunity to actually follow people for longer, people who may not be well enough to come to clinic or might have actually just not shown up for that appointment, but they would show up on a telehealth. And yet, who's disadvantaged by that as well, by the technology or the access to the technology? Thank you. Mira, as we sort of work in this system of healthcare and I'm just thinking about the things that you've noticed in terms of your policy and your policy hat on, and I was thinking about the broader community and responding to COVID and responding to the climate crisis. What can palliative care sort of contribute to in the broader system of healthcare, or indeed learn from in the broader system of healthcare, in how we should sort of respond going forward?
No, I remember reading a story, and I think it was in the Sydney Morning Herald, around the time of the New South Wales bushfires, well before we even knew that a few weeks later we would be moving into an international pandemic, about a daughter who was caring for her mum who had dementia in the community. And this poor daughter was thinking about the logistics of evacuation. They lived in an area that was pretty soon to be impacted, and indeed I think did have quite significant impacts during the bushfire. And the logistics and the decision making of thinking about how and to where you would evacuate with a bedbound mother with advanced dementia. And I just thought at that time, reading that article, why can't we have community-based systems that actually would be able to respond to that? If we could work out how to respond to that challenge, then everything else would fall in place. And that story has come back to me several times during, I think, the last 2 years as we've been thinking through the pandemic and the challenges. And I think the things that palliative care offers is preparedness and prevention, and that we think we're very good at thinking about every single possible problem that may or may not happen, and having a plan, no matter how ridiculous or left field that solution may be. But we're problem seekers, and we think about the problems that may happen and then put plans in place. And I think that would be one thing that I think we really do bring. And then I think it's the personal connection that that's such an important thread throughout the work that we do. And we have been able to think about how you could apply that in extenuating circumstances. So I think if we really could work out how we mobilise authentic community-based care and stop investing in buildings and larger buildings, and shift some of that resource to effective community systems that are integrated with the social fabric of the community around them, then I think we would have learnt a lot from the last few years.
Thank you. Carmel, I wonder if you would be, you've seen many people in positions of leadership over different times and also over this year. I wonder if you'd be willing to comment on some things that you've noticed or learned about or thought about leadership over the last year.
I think I was very glad that I wasn't running the service through COVID. I must admit, the wonderful girl Faye that took over my position, I did feel for her at times. I just think that especially in community palliative care, I just think that the managers of those services did an amazing job and are still doing an amazing job keeping their staff going, keeping the wishes of patients who wanted to die at home as much as they could, allowing them to do that in face of all the changes. And I think I did speak to Faye at Golden Valley Hospice about that when she asked me to come back to work. One of the things that I think drove them all mad was that every week the department had changes. They'd set something up and then get to work on Monday and the department would have changed their mind and there'd be something else that they had to do. And just keeping on top of all of that while still letting the girls, trying not to involve the girls too deeply in it so they could still keep doing the work that they had to do out in the community. So I think to have managed community services through that and allowing people to die at home through that the last couple of years has been an amazing achievement for all of the managers of community palliative care services, whether they're standalone or in hospital.
Thanks, Carmel. Dish, would you like to comment on that? Things that you've noticed about leadership over the year?
Yeah, look, I think so probably wearing my leadership hat or hats. I think there's been a couple of things. One is so I'm a big fan of Stephen Covey's work. I'm sure some of you are familiar with it, 7 Habits of Highly Successful People, that kind of thing, but highly effective people. But, the one is really, the one that stands out from that is that seek first to understand and then be understood. So I think really trying to understand what's going on with your team and how they're feeling about things. Some people do really well working from home. I do really well. Some people hate it and want the social interaction of being at work. So you've got to listen and try and understand. And I think you can kind of get into this organisational thing of saying, okay, well, so there's obviously support services and things available to people. But I think if you tell people, okay, we're going to try and help you be resilient through it, that's actually a good way to really irritate people sometimes. You're actually better off coming up with some practical things that are going to help them. So I think, for us, it's actually been about trying to work on some service improvements, business cases, things that we have wanted to do, and just not let those come to a grinding halt because of COVID. That really helps your team feel like, you're supporting them practically. There was something else I was going to say about leadership. It's slipped my mind now. Look, that's probably.
Thanks, Dish. No, that's great. Thank you. There's a few questions from the audience, and I'm wondering, maybe I might just leave it open and see if anyone in the panel would like to comment. Dr. Das has joined us from India. Welcome, Dr. Das, and has suggested that countries having stronger and sustainable health systems will come out successfully post-COVID pandemic, and that there's obviously lots of potential gaps. And I guess just asking comment on that. Dish, are you happy to take that up?
Yeah, it's interesting. I think, so I do have an opinion, sort of, and it's not a specialty palliative care opinion. I think that in the West, and I can't speak for, other countries, but I think in the West, rates of vaccination are going to have a long-term dramatic impact on health services. So, our head of ID at Western Health talks about this. If you think about, if you've got an 80% vaccinated population versus a 90% vaccinated population, you think of it as a 10% difference in vaccination rates. But from a hospital perspective, what that means is it's actually double the rate of demand on your health service from the unvaccinated, 10 to 20%. And 5 versus, say, 30% is 70% versus 95%. So again, doesn't sound like that big a difference, but that's 6 times the demand of COVID patients. And we know from, what's happening in the US, and I'd certainly be interested in what's happening in India now, because we heard a lot about it some months ago, but things have presumably changed a lot since then. But the demand on health services from those unvaccinated people is going to crowd out all of your other activity. We have been very, very fortunate in Australia to get up to good numbers of vaccinated people before, there was spread in the community. So I think that's going to be a long-term thing, and it's actually going to lead to things like, if I was a healthcare worker in a state in the US with really low vaccination rates, I'd be thinking about how I could move to somewhere else where I would have a better experience in my career. And so I think there's going to be some really important impacts of that kind of thing.
Thanks, Dish. The time's gone quickly, and I wanted to give you all an opportunity to talk a little bit about, we usually finish these sessions with quotes, and I want to just introduce or put the background to the quote, which is taken from Eddie Yarko's book. He was born Abraham Shlomo Jakobovits, and he died on the 12th of October this year. He was born in Germany. As a teenager, he was swept up in Kristallnacht as the stormtroopers sort of invaded his home, invaded his world, and he was sent to a concentration camp. He was in and out of concentration camps really for the war, and ultimately in Auschwitz, which he survived, but his parents did not. He managed to escape while on the death march and lived in the forest until he was found by American soldiers. A few years after the war, he immigrated to Australia with his young family, and from 1992 served as a volunteer at the Sydney Jewish Museum, giving first-hand accounts of surviving the Holocaust. He refused to be consumed by his war experience. Instead, after the birth of his son, he made a conscious decision that he'd be happy. Not an individualistic happiness, but a happiness that stems from relationships and love and community and taking time and being. In 2013, he was a recipient of the Medal of the Order of Australia. Aged 99, he released a TED Talk, and at 100 published a memoir, The Happiest Man on Earth, and it became an immediate bestseller. And I want to take two quotes from this book. The first is, if people had stood up then on Kristallnacht and said, enough, what are you doing? What is wrong with you? Then the course of history would have been different, but they did not. They were scared, they were weak, and their weakness allowed them to be manipulated into hatred. The second quote is, a field is empty, but if you put in the effort to grow something, then you'll have a garden, and that's life. Give something, something will come back. Give nothing, nothing will come back. To grow a flower is a miracle. It means you can grow more. Remember that a flower is not just a flower, it's the start of a whole garden. So as the year draws to a close and we think about the year ahead and we consider the courage and also the creativity that was spoken of by Eddie Yarkle, what flower or flowers should we be cultivating? Carrie?
I choose bluebells because they are the flower of kindness. And I think those two quotes for me bring up the choice that we always have between love and fear. And we've seen lots of terrible things happen, certainly politically in the world in the last few years, because fear has been just pushed so much. But I think there is a growing understanding of how powerful kindness is. We know the more we're learning about trauma, we know how different it can be when someone just is kind to you, when you have to go to a human service organisation, for example, and they remember your name. And it doesn't take very much, but to be recognised as an important human being and to have our suffering recognised changes everything. And it sounds really simple, but I think we are understanding more and more of how powerful that is. And we have to fight fear because that brings out the worst. So it would be bluebells in my garden.
Thanks, Carrie. Mira, what does those quotes prompt for you?
Yes, I thought of people that really the flowers that we're really cultivating are the people, whether it is the people with a palliative diagnosis or the people caring for them, the broader community and the care and health professionals. But you can't cultivate the people without thinking about the soil, and that's where I think the policy and investment and actually having a longer term view. And my COVID hobby has been looking into permaculture and regenerative agriculture as podcasts as I drive to Liverpool. And so the things under the soil and how we nurture those really came to mind when I read those quotes. And then I think sunshine and water, and so that well-being, and that we have this health workforce and carers that have put phenomenal yards in over the last few years. And I think, as Carrie says, we have to nurture and build that workforce so that can be sustained, because those people really will matter as we continue to provide healthcare going forward.
Thank you. Gish?
Look, I think the thing I'd say about that, the first quote about people standing up and being heard. I think, I know there's a lot of members of the palliative care community on this call, and I'd really like to congratulate the palliative care community for doing that through this crisis, because, so much has fallen on palliative care. Whether that's been in hospital, managed dying COVID patients, being in the community, stepping up to manage patients who haven't been coming into hospital. So I've been really grateful, and there's no doubt in my mind that the palliative care community has stood up to be counted and has really provided a great service for the Australian community. So I'm very grateful, as a non-palliative care practitioner for what's happened. So that's what comes to mind for me.
Thanks, Dish. And last word to Carmel.
Yeah, I agree with everyone, and I think that one of the things that I look at in the palliative care community across Victoria and across Australia is the fact that we have done well through this COVID crisis, and that the staff have been able to do their jobs, and the nurses, and maybe that they, not to be scared to speak up and say, well, if this ever happens again, we need more support in the community to do the job that we have to do, and get the resources in. And the flower, well, mine's always been a daffodil, and it always will be the sign of hope, and it's always a sign of spring coming and better things to come. And anything that gives families and people joy, and flowers have always done that, I think makes their lives a little bit easier and happier.
Thanks, Carmel. That's terrific. Thank you. So I think that draws the session to a close. I want to thank the panel for what's been really a great and rich and warm and thoughtful discussion. So thank you, Dish, to Carrie, Carmel and Mira. I really appreciate your time and thinking through and so generously giving your thoughts this afternoon. I want to also thank Tanya Fraser and Stacey Panozzo, who are the critical cogs that help organise all of this, and I'm really grateful for your help over the year with the Perspectives. And thank you also, you, the audience, for coming along and participating and putting things in the chat and being part of making these a success. We will be back next year for a whole new year of Perspectives, and I hope you'll you'll join us and also enjoy it. Have a good summer, everyone, and for those of you who celebrated, a good Christmas, and we look forward to seeing you all in the new year. So thank you.